to the PAD podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter and Instagram with the handle bar at Shafir Ahmad 4109. And please feel free to share these chunks of knowledge. Thank you. Today the topic of our discussion is Alzheimer disease. So before jumping into the detail of Alzheimer disease, first of all we have to understand what dementia is all about. So Alzheimer disease is one of the disease that comes under the heading of dementia. And dementia is a memory loss plus cognitive dysfunction but without any loss of consciousness. So this is an important point which we have to keep in our mind, is that in dementia, there is no loss of consciousness. So Alzheimer disease is the most common cause of dementia in the elderly population. The disease usually manifests with the insidious onset of impaired higher intellectual functions and altered mood and behavior. So it's a disease that is having an insidious onset, meaning that it just grows slowly and gradually and starts impairing the function of higher intellectual functions, and then it starts affecting mood and then behavior. But later this disease progresses towards disorientation, memory loss and aphasia, and these are the findings that are indicative of severe cortical dysfunction, and over another 5 to 10 years the patient can become profoundly disabled, mute and immobile. And death usually occurs from intercurrent pneumonia or other infections, because these patients are prone towards infection. For example, if they are losing the function of, let's suppose, swallowing, so what will happen, that they are prone towards respiration pneumonia. So similarly they are also prone towards other infections as well. Age is an important risk factor for Alzheimer disease, and the incidence is about 3% in persons 65 to 74 years old, 19% in those with 75 to 84-year-old age, and 47% in those older than 84 years. So if you can see that the incidence is rising proportionally with the age. So as the person ages, so the chances of developing Alzheimer disease increases exponentially. So most cases of Alzheimer disease are sporadic, but at least 5 to 10% are familial cases. And the sporadic cases rarely present before 50 years of age, but early onset is seen with some heritable forms. So now we will discuss the pathogenesis of Alzheimer disease. Study of the familial forms of Alzheimer disease supports a model in which a peptide called beta amyloid or A-beta accumulates in the brain over time, initiating a chain of events that result in Alzheimer disease. So the question arises that what is this basically the peptide called beta amyloid or A-beta, from where it emerges out? So A-beta or beta amyloid is created when the transmembrane protein amyloid precursor, also known as APP, is sequentially cleaved by the enzymes beta amyloid converting enzymes base and gamma secretase. So how beta amyloid or a beta amyloid peptide emerges out? That it emerges out from transmembrane protein amyloid precursor protein APP upon the cleavage of enzyme base and gamma secretase. So what happens that, if you can see that amyloid precursor protein is basically a receptor, transmembrane receptor. So there are 3 cleavage sites present on that amyloid precursor protein transmembrane receptor. One site is known as beta secretase, the other site is known as alpha secretase, and the third site is known as gamma secretase. So it has 2 different fates. One is that it can convert into non-amyloidogenic pathway, and the second pathway it can lead towards is amyloidogenic pathway. So what happens in non-amyloidogenic pathway is that there will be alpha secretase cleavage and gamma secretase cleavage, leaving behind the beta secretase site. So what will happen that enzymatic functions enzymes will start cleaving this transmembrane receptor at alpha secretase cleavage site and gamma secretase cleavage site, and this is the non-amyloidogenic pathway. And the other pathway, which is known as amyloidogenic pathway, what happens that there will be cleavage at beta secretase cleavage, and then there will be gamma secretase cleavage. So there will be beta secretase cleavage, gamma secretase cleavage, leaving behind a beta peptide, which will be a monomer. So what will happen that monomer will combine with similarly other A beta monomers and will form A beta oligomers. So these oligomers, when aggregate, we will call that A beta aggregates, and it can convert into amyloid fibrils, and hence it will convert into plaques and tangles, which we will discuss shortly that what's the basically difference between plaques and tangles is. So A beta oligomers can form A beta aggregates, amyloid fibrils, and can convert into plaques and tangles. Similarly, A beta oligomers can go towards the kinase activation pathway, in which there will be tau protein phosphorylation, and when tau protein phosphorylation will occur, what will happen that microtubule which is present inside the neurons, so there will be disassembly of those microtubules, and then it will cause neuronal damage. Similarly, tau phosphorylation can cause tau aggregation, can convert into plaques and tangles, or can lead towards the neuronal damage. So in this, all A beta oligomers can form A beta aggregates and can activate the kinase activation. There can be synaptic dysfunction, there can be cell death, and ultimately the end goal is the neuronal damage. So A beta peptide genesis and consequences in the Alzheimer disease. What will happen that amyloid precursor protein cleavage by alpha secretase and gamma secretase produces a harmless soluble peptide, whereas amyloid precursor protein cleavage by beta amyloid converting enzyme base and gamma secretase releases a beta peptide which forms pathogenic aggregates and contribute to the characteristic plaques and tangles of the Alzheimer disease. So there are two pathways. One is forming the harmless soluble peptide, and other is forming a harmful peptide in the form of a beta amyloid, and which will convert into plaques and tangles. So as discussed previously, that APP can be cleaved by alpha secretase and gamma secretase, which liberates a different peptide that is non-pathogenic. So mutations in APP or in components of gamma secretase due to genetic mutations in presenilin gene 1 and presenilin gene 2 can lead towards familial Alzheimer disease by increasing the rate at which A beta amyloid is generated. So the APP gene is located on chromosome 21, and the risk of Alzheimer disease also is higher in those with an extra copy of APP gene, such as in Down syndrome patient, also known as trisomy 21, and persons with small interstitial duplications of APP. It can lead towards the greater A beta or beta amyloid production. The other major genetic risk factor is a variant of apolipoprotein E called epsilon 4, and each ApoE4 allele that is present increases the risk of Alzheimer's disease by approximately 4-fold and also appears to lower the age of onset. But how it influences A beta amyloid accumulation is unknown till date. It may increase the A beta aggregation or deposition or decrease A beta clearance. So, while large deposits of A beta are a feature of end stage Alzheimer disease, small aggregates of A beta may also be pathogenic as they alter neurotransmission and are toxic to neurons and synaptic endings. So, large deposits in the form of plaques also lead to neuronal death or elicit a local inflammatory response that can result in further cell injury and may cause altered region to region communication through mechanical effects on axons and dendrites. The presence of A beta also leads to hyperphosphorylation of neuronal microtubule binding protein known as tau protein. So, the increased level of phosphorylation causes tau to redistribute from axons into the dendrites and cell bodies where it aggregates into tangles, which also contribute to neuronal dysfunction and cell death. Now we will discuss about the morphology, and we will just discuss in much more detail that what are basically neuronal plaques and what are tangles. So what happens in Alzheimer disease, the macroscopic examination of the brain shows a variable degree of cortical atrophy resulting in a widening of a cerebral sulci that is most pronounced in the frontal, temporal and parietal lobes. So what happens that with significant atrophy, there is compensatory ventricular enlargement, which is known as hydrocephalus ex vivo. So with this atrophy, hydrocephalus is also developing, but this hydrocephalus is not because of increased CSF or decreased CSF. It is just because of the atrophy of the cortex, and hence it is called widening of the ventricles. So at the macroscopic level, Alzheimer disease is diagnosed by the presence of plaques. Now plaques is an extracellular lesion, and neurofibrillary tangles, which is an intracellular lesion. So the first basic difference between the plaques and tangles is that plaques is an extracellular lesion found outside of the neurons, and neurofibrillary tangles is an intracellular lesion. Now because these may also be present to a lesser extent in the brains of elderly non-dementia patients, so the current criteria for a diagnosis of Alzheimer disease are based on a combination of clinical and pathological features. So there is a fairly constant progressive involvement of different parts of brain like pathological changes, specifically plaques, tangles and associated neuronal loss and glial reactions. So they are first evident in the area of the cortex known as entorhinal cortex, and then in the hippocampal formation, and then in the isocortex area, and finally in the neocortex. This all lesions start developing. So silver staining or immunohistochemistry methods are extremely helpful in assessing the true lesion. So neuritic plaques are focal spherical collections of dilated tortuous silver staining neuritic processes, which are basically dystrophic neurites, often around a central amyloid core. So there is a central amyloid core, and then there are some dystrophic neurites. So with these two, when they are combined, so we will say that it's a neuritic plaque. So neuritic plaques range in size from 20 to 200 micrometer in diameter. Microglial cells and reactive astrocytes are present at their periphery. Plaques can be found in the hippocampus and amygdala as well as in the neocortex, although there usually is relative sparing of primary motor and sensory cortices until late in the disease course. So the amyloid core contains A beta, and A beta deposits can also be found that lack the surrounding neuritic reaction termed diffuse plaques. So A beta deposits also can be found that lack the surrounding neuritic reaction termed diffuse plaques, and these diffuse plaques are found in the superficial cerebral cortex, basal ganglia and cerebellar cortex, and may represent an early stage of plaque development. But generally the neuritic plaque is composed of A beta amyloid as well as dystrophic neurites. So plaque is basically an extracellular lesion. So what are the tangles? Neurofibrillary tangles are bundles of paired helical filaments visible as basophilic fibrillary structures in the cytoplasm of the neuron that displace or encircle the nucleus. And tangles can persist after the neurons dies, and once the neurons starting dying, what will happen that these tangles can become a form of extracellular pathological lesion, but they are generally intracellular lesions. So they are commonly found in the cortical neurons, especially in the entorhinal cortex as well as in the pyramidal cells of the hippocampus, the amygdala, the basal forebrain, and the Raphe nuclei. A major component of paired helical filaments is abnormally hyperphosphorylated tau protein, and tangles are not specific to Alzheimer's disease because it is found in other degenerative diseases as well. So this concludes our podcast of the Alzheimer disease. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.